All right, well, welcome everybody. It's nice to see everyone. In the fashion that is San Jose State University, we've taken duct tape and gum and strewn together a network of hotspots from people's phones to make sure we could deliver this today. So I want to thank this team in the library for thinking through all this, and I would like to thank AT&T for giving me a hotspot with my plan that we can run that computer over there. So the job never ends, as you like to say. Anyway, this is exciting. It's fantastic to have the University Scholars Series. Dr. Marcelle Dougan will be speaking. I got a few kind of introductory things, and then I'll introduce the speaker and turn it over to her here today. So let's jump in and let's begin. And I think I can go this way. Is that one? Okay, I'll stick with this one. So you may end up with, well, we'll figure it out. Okay. Oh, what did I do? I hit the wrong button. Darn it. Now I'm loading. This is emotional. This is not physical. This is me loading. What did I do? I hit the wrong button. Oh, I did nothing? Oh, it's the network. Okay, good. Okay, well, let's just pretend that we no longer have network problems. Yeah, I'll just read it from here. Yeah, I read this. Okay, we're gonna go analog here, people. The key to San Jose State is our adaptability. Okay, so I'm gonna start with the land acknowledgement. While we gather at San Jose State University, we are located on the ethno-historical tribal territory of the Tami and Ohlone, who were the direct descendants of the lineages enrolled in the Muwekma Ohlone tribe and who were missionized into Mission Santa Clara, San Jose, and Dolores. The lands on which San Jose State University is established was and continues to be of significance to the Muwekma Ohlone tribe. We also recognize that the ancestors of the Muwekma Ohlone constructed and maintained the 3 Bay Area missions. Our campus extends to the surrounding areas that held a tupantak, a traditional roundhouse, which was once located at the historic Lope Niño land grant, Rancho Posolimi y Positas de la Animas, the Little Well of Souls, and also Marcelle, Pio, and Cristobal's land grant, Rancho Ulisac, which were places of celebration and religious ceremonies, as well as nearby ancestral heritage shell mounds that served on the tribe as the tribe's traditional cemetery sites and territorial monuments. San Jose State University also desires to honor the military service of the Muwekma Ohlone, who've honorably served overseas during World War I, World War II, Korea, Vietnam, Desert Storm, Iraq, and are still serving in the United States Armed Forces today. So with that, a couple of housekeeping items, although we have no idea if we'll actually be able to see any of this stuff. And we got some chats in here. Anything important I need to know, Maria? Okay, beautiful. I'm just going to ignore that. So we're going to use the question and answer for those online. You can put the Q&A in. We're recording, I think. We're transcribing, we hope. And when it's all said and done, we'll have a nice video of this. With that, I want to turn to our speaker today, Dr. Marcelle Dougan. I had the opportunity to interview Dr. Dougan as part of my podcast, The Accidental Geographer, and it was just one of my favorite conversations, not just because her research is so fascinating and important and interesting, but because of the ways in which Dr. Dougan approaches the intersections of research and teaching and the service work she does. She has this incredible history working in industry, coming back to higher ed. She's lived in multiple places, having been born in Sierra Leone and moved around. And we even found out we have a similarity of having lived in central Pennsylvania for a number of years, where she worked for Merck, right? Yeah. She completed a master's degree at a small school in New York called Columbia, I think. Yeah. Then went on to, what is it? Harvard. Okay. All right. She probably gets these jokes all the time. It's an incredible resume, and her work has gone from questions of maternal health into questions of what epidemics mean, how we think about vaccination, and questions even to mental health of children today as they think about themselves in a post-pandemic world. So it's an absolutely fascinating. I'm very much looking forward to the talk today, and I want to welcome Dr. Dougan to the stage.
Okay, Thank you, Vin, for that introduction, and welcome everyone. Thank you so much for being here. I'm so excited to see you all, and thank you for making the time. And, you know, as we power Silicon Valley, we're doing our best to roll with the punches. Okay, so question for you all. What was the first inkling that you had around the pandemic that something was fundamentally different, something had changed or something was changing? What was your first inkling? What was that? Yes, Miranda.
And then they were going to go to some military base. And I was like, oh my God, they're right there.
Yes, thank you. Do you remember what date roughly? Okay, all right, thank you. Yes, Josh. Yes. You remember the time frame? Okay, yes, thank you. Anyone else? Nathan?
The presidents and stuff, or the principal at our school was saying, oh, it's just going to be 2 weeks. And then it became 3 months, and then the semester, and then all the way up until the rest of half of my high school experience. So, you know, that's when I had a clue that something wasn't right here.
Yeah. Okay, so there's always something, right, that triggers that, yeah, something is happening. For me, it was March 16th, I remember, and we were listening to a video on Zoom. By that time, we were sort of doing interviews. It was a new faculty search, and we were doing interviews on Zoom. But my husband had gone to the grocery store, and then he said, the shelves are empty. You know, and that was when I thought, wow, something is happening. So I grabbed the other kid and went to another grocery store, and then it just sort of started from there. And so it took about a week. You know, we were sort of just managing and just hitting our stride. And then a week later, I just broke down and just cried because I didn't know what was happening. It was just so big, you know. And then right then, I just decided that the only way to get through this was just to focus on that current day. Otherwise, it was just too big. So my thing throughout the pandemic was, you know, a day at a time. And that was how, you know, I was able to get through. But we went on Zoom with aplomb. We did our best. It was all about the backgrounds. And then after a while, we didn't even care who was being seen, you know, in our backgrounds or anything like that. And then we baked, right? We cooked a lot. There was a lot of, you know, sourdough starters and all of that stuff being shared all over. I have one son who has a gluten allergy, so I perfected gluten-free cooking. So these are all gluten-free beignets. I learned that you can't punch the dough for gluten-free dough because it doesn't like it. So, you know, just doing my best and just trying to get through the best we could. But, you know, at the same time, from 2020 to now, we have, you know, about 683 million cases across the world and 6.8 million deaths, right? And then just looking at the daily cases, we can see that, you know, January of 2022, there was a huge peak again. And now, you know, March, April 2023 was sort of on the downward slide. Deaths also had a similar pattern, you know, across the world. Then in the US, we followed that same similar pattern. And it was encouraging to see right here that, you know, even though the diseases peaked back in January of 2022, probably Omicron, which started around November of 21, the deaths did not actually hit that peak. You know, so there was something going on, maybe some immunity, vaccines were working, etc. So it wasn't as disastrous as it could have been. Nevertheless, in the US, we had about 106 million cases and 1.2 million deaths. And considering that the US is 4% of the global population, it still made up about 15% of the cases and 18% of the deaths. So the situation in the US in many ways was worse than in other parts of the world. So if you think about the pandemic, right, and in terms of how it was talked about in the media, in the general population, what is one word that you heard being used or maybe overused? What was that one word? Anyone remember? There was a word that was just so overused. Unprecedented. Okay, we'll get there. But, you know, at the same time, when all of this was happening, we saw in the news, the coronavirus exposed health disparities in communities of color, right? Food insecurity was a big problem. Millions of people were facing food shortages, hikes in prices, and just, you know, loss of employment led to really acute issues of food insecurity. We began to hear about the risk factors for disease, you know, high blood pressure, obesity, all of that. College students were miserable about going online. And so there were class action lawsuits all over the place. A rise in hate, anti-Asian sentiment, 150% in 2020, and still high in many areas. George Floyd, we were all home and watching, and I think that was, you know, a blessing and a curse. Many of us were home so we could observe what was going on in a way that had we been busy commuting up and down, we would not have realized it. But it was horrific. But in many ways, it changed the conversation in this country. In public health, we had been talking about structural issues for a long time, but it was then, I think, structural racism and all those concepts became part of our larger fabric in the US in that conversation. You know, people were talking about systemic racism. There was a push in many organizations, even here at San Jose State, to engage with faculty of color, in particular Black faculty, to understand what some of the issues were. And these are still ongoing. And so then, you know, throughout 2020 and then the end of 2020 brought with us some hope, right? Some hope with the vaccine and how it was highly effective and it promised some relief for what we were going through. I remember when I went to get the vaccine, it was March 6th of 2021 for my first dose. And I was so excited. I dressed up. I had a lovely necklace. My husband's like, "Where are you going?" Like, to get my vaccine. I called my cousin, it was her birthday, on FaceTime. She's like, "Why are you dressed up?" I'm like, "I'm going to get my vaccine." And it was just so full of hope. And it was, you know, it signaled in many ways the end of what we were dealing with. However, you know, then again, we had breakthrough cases. And so, okay, so the vaccine wasn't working as well as we had anticipated or hoped. People were, you know, getting sick even after the vaccine. And then come the variants, along come the variants, this and that. This was just last week, a new variant in India. So in many ways, it just seems like we're in this infinite loop, right? Dealing with COVID and it's never gonna end. So in many ways, it's just a kind of a part of what we're dealing with today. Okay, so for today, I'm going to talk about the importance of the coronavirus, some findings from epidemiological studies that I have been involved in, and then a look ahead to what's coming next. So back to that word, right? Matt has kindly told us that, you know, the unprecedented word was the one word that was overused as a result, you know, during the pandemic. Unprecedented. Well, how unprecedented was it? So this slide shows the context of all the previous pandemics or plagues and whatever that we have experienced since about the 1300s. You know, thinking about the bubonic plague, it killed about 200 million people, smallpox, 56 million people. COVID-19 is right there, you know, here, around 7 million people so far. And keeping in mind the population shifts, what does it look like as a fraction of the world's population, right? And so the Black Death definitely is up there. And COVID-19 is right at the bottom in terms of the context of it. Having said that, 7 million people is a lot of people, right? That's to think about a disease that probably could wipe out 90% of the Bay Area or 20% of California. That's a lot of people. So it does matter. Even if in the grand scheme of things, it's, there have been worse plagues, this is a bad one that we're currently living in. And so it is important in understanding and dealing with as well. So in terms of diseases, and just to put the COVID-19 in context of other diseases, in epidemiology, we use a term called R0, which is the basic reproduction number. Okay, it's a measure of how the disease is going to spread in society. So R0 is a function of three things. One, the contact rate. Two, the duration of infectivity, and then three, the risk of the probability of transmission when one infected person comes in contact with a susceptible individual. So if R0 is 1, then the disease is in a steady state in the population. If it's greater than 1, then it spreads. And if it's less than 1, then it's on the decline in society. So with COVID-19, the original strain was about a 3.0. So for every one person that was infected, then they could infect 3 people. The latest strain is around 9. And then other diseases like MERS, Middle Eastern Respiratory Syndrome, that's about 1.8, so it's on the decline. The flu is about 1.5. HIV, which is another recent pandemic, that's between 2 and 5, okay? So just to put this in context, and then measles is up there, from 12 to 18. For R0. So with COVID-19, then with this latest, Omicron anyway, there's several different variants of it, but for every one person that gets infected and that person comes into contact, they could influence potentially 9 individuals. So, in terms of the COVID-19 and what public health officials were doing there, they were trying to interrupt. We couldn't really interrupt the duration, right, of the disease in that sense. But, by masking, we wanted to reduce the likelihood of transmission. And by staying at home, we wanted to reduce the contact rate of the disease, all in an effort to reduce this R0 number. So with that, the first inkling I had that there was some disparities was a tweet that came up talking about Michigan. So initially we did not have racial data. Eventually we began to get some. And in Michigan, some data suggested that even though only 14% of the population was Black, they made up 35% of the cases and 40% of the deaths. So that was my first inkling. This was early April that this tweet came out, and we began to pay a little bit more attention to these disparities and what was causing them. So very quickly, the disparities were apparent. So here, this shows, the blue line shows the data disparities for deaths, coronavirus deaths in 2020, and the yellow line shows 2022. So relative to whites, 1.0, their risk is 1. In 2020, American Indians had a 1.4 times the risk of death. Asians had about the same as whites. Blacks had about 2.1, and Hispanics and Latinos had about 1.0. Shift forward 2 years, certain things have changed, and then American Indians and Alaska Natives are quite a bit worse off, as Hispanic and Latinos, and then Blacks and Asians have improved slightly. Blacks are still relatively high, but Asians are actually lower than whites in their risk of death from the virus. Okay, so in terms of, so not only race was a big risk factor, but other things like, so having for severe disease or death. Having diabetes increases the risk of severe disease by 4 times, heart disease by about 3 times. Male sex or male gender probably increases the risk about 2 times. And then the risk of death for those who are 65 and older compared to those who are below 65 is about 9 times the risk of death. And then grocery shopping, right? Who remembers just being terrified of grocery shopping? Do you all remember the video of that man who was washing his groceries with soap and all of that and showing people how to do it? And luckily, my kind colleague here, Dr. Katie Wilkinson in biology said, if you wash your food with soap, you'll get diarrhea. That was enough for me. I was done. But I know some people who were washing their groceries, right? So I don't think there was a risk. And she convinced me that our stomachs have enough acid, to neutralize any kind of virus. So we didn't have risks necessarily from ingesting food. Okay. So, but, in terms of the grocery shopping, there were very real fears there, right? In terms of going to the supermarket. I remember the first time I had gone, maybe after about 2 weeks, I was walking around the store so fast in my mask, I couldn't even breathe. Like my husband's like, what's wrong with you? I gotta go outside, I have to go. But it was a pretty scary time. I think just all the unknowns and everything that we didn't know about. So the next thing I'm going to talk about is some findings from my study. So the way I got involved in this COVID work, just thinking about everything that was happening, hearing about the racism, the public rhetoric against Asian Americans, hearing about the disparities and how people of color, especially Blacks, were suffering, the whole social context at the time, food security, all of that, my students and I just began to collect data. At the time, we had different sources of data, and literally they were just scraping the data from very different websites every day. And we just started building maps just to look at what was happening across the country, across California, across the different counties, comparing California to the Bay Area, all of that, and all the different counties, and just trying to understand really at a descriptive level what was going on. And so I had applied for a grant, a central risk grant, to look at county level statistics, county level factors in relation to coronavirus incidence and mortality. And, just trying to understand at a structural level, because, we knew a lot about the individual risk factors, but how do those factors play at a structural level? Are there policies that we could implement at a higher level that would reduce the risk of disease? And so I was interested in that. And so that's how my work in this area started. And then I presented at one of the RISCA in 5 sessions. And then another colleague got me interested in issues of food security. And another colleague reached out separately about understanding the effects in Asian Americans. And then a third one reached out about the student population. So I'm going to be talking about all 3 of those studies today. So the first one is the COMPASS study, which is about the COVID effects on mental and physical health of Asian American and Pacific Islanders survey study. And so what was really important about this study was that typically in any kind of epidemiological study, Asians are all grouped as one, okay? But that's a very heterogeneous population. Koreans are different from Asian Indians, who are different from Chinese, who are different from Hmong. So all of that, we had the opportunity to just look at just Asian Americans and Pacific Islanders. And so I actually was just recruited by chance. The statistician on the project dropped out, and literally a colleague contacted me from UCSF. Can you do it? We have 2 weeks to write the grant. I'm like, where do I sign? And so I jumped in because I knew something important was happening and I wanted to be part of that conversation. And so So we wrote the grant, I think it was in May, and it got approved a few months after. And we recruited 5,420 Asian American and Pacific Islanders across the US from October to January. And then after that, we maybe recruited so it was about 5,000 initially, and then we got a few more through focused recruitment with community partners. And then we closed that in May of 2021. And then later in December, then we did another follow-up study. So it was great in that now we have some data over time and have the opportunity to look at how things have changed. The survey was unique. Again, it was administered in 5 different languages, predominantly English, but also Korean, Vietnamese, Chinese, and Samoan. In that population, discrimination is prevalent. So 3 in 5 people reported experiences of discrimination. And as you can see, it varies by cultural group. So again, if you're just grouping everyone in one, you can miss these kinds of important differences between groups. And then we also found out in the follow-up study, just looking at descriptive statistics, experiences have persisted over time. So there was that acute phase in the middle of the pandemic, but also over time, and in some cases, some groups are actually reporting higher rates of discrimination. We also looked at some different studies. One of them was social support in relation to technology use and mental health outcomes. What was striking when we looked at the prevalence of anxiety and depression is that things had become dramatically worse in that first year following the pandemic than these numbers pre-pandemic were 2019 numbers. And things and anxiety and depression had dramatically increased in that population. But when we looked at social support as measured by friend support and family support was protective against mental health outcomes. But the younger adults were more at risk for poorer outcomes. It was better in older adults than in younger adults. Also, we found that people who were using technology for 6-7 hours a day or more were also more likely to have mental health outcomes. And there was an interesting interaction where those with lower support, the effect of technology on mental health was even stronger and more adverse. And then we also found that Korean Americans also appeared to be at higher risk. And so some questions about what does this mean? How do we improve mental health outcomes in this population? What kinds of support younger people need and going forward? Okay, so the other study that I worked on, I was invited by Dr. Gisele Pignotti of Nutrition to be the co-director of the Bay Area Center for the National Food Access and COVID. This study was a collaboration of faculty who they all sort of knew each other and had worked together and were in different parts across the country. We had 18 study sites across 15 states in the US and a population, and we all pulled our data together of population of little over 27,000. And we looked at food security and food access questions in the pandemic. So why is food insecurity important? Well, it puts people at risk for chronic diseases such as diabetes and cardiovascular disease, right? And some cancers as well, because we have found that some people who are food insecure might go to food banks and they get food from cans that are stored in cans. And those cans sometimes have some lining materials in them that could increase the risk of cancer. So food insecurity is definitely a public health problem. But we looked at food security and food access during the first year of the pandemic. And then we have since collected some follow-up data to look at, since that acute first year, what else is happening. And we have seen from other studies of humanitarian crises that some of these effects can linger for many years. They're not gone the minute the condition is gone. So this is a bit of a busy slide, but I'll just walk you through it. So we had 3 types of samples. One was representative, where the researchers tried to get a representative sample of the population in terms of things like income, race, and ethnicity. And then the next bit was the convenience sample, where we just surveyed, depending on the center, where we just surveyed people who happened to complete the survey. And then the last set was the high-risk sample, where we looked at communities, oversampled communities that were at high risk for food insecurity, like people of color, for instance. So, but basically, the big picture for this is that in almost every type of sample, with the exception of New Mexico, we don't know what was happening there, but everywhere in the country, there was an increase in food insecurity. Here in California, in the Bay Area, we were among the worst in the country in terms of food insecurity. So this is just delving deeper into what was happening in the Bay Area. And we found that 1 in 5 people were new users of food assistance. And then also people of color were at risk, those who were Hispanic, and then those households with children under 18 were also at high risk of becoming food insecure. And then, so just looking at the data, trying to understand what concerns people had about obtaining food, people were grateful for the food banks and food assistance so that they could, because the Bay Area is so expensive. And so people had to make choices between what they ate and paying rent, right? And then some issues with seniors, providing them with reliable delivery so that they didn't have to go out into the store. I know we did that at my church, and like we had the youth go out and buy food for the senior population. And so, you know, that was definitely a prevalent concern in the community. And then also with food stamps and food assistance, no Walmart, for instance, uses EBT online. So again, so not only people on food assistance, they can't even buy food safely, right? And so all of these were, you know, just what people reported that they were observing. And then the other thing, so I had mentioned, we talked about individual factors, but we also wanted to understand how structural factors affected food insecurity. So we looked at a measure called the Healthy Places Index, which is a measure of how healthy the population is. So it has like 25 different indicators across 4 domains, which are education, housing, security, education, housing, income, and also social factors, right? And so this is just of the Bay Area counties looking at, relatively speaking, so it's on a range of 0 to 1, and then the higher number being the more healthy neighborhood. And so Santa Clara County is pretty healthy, but right in the Bay Area, you have differences as well. You know, Solano County is close to the bottom, right? But what we found is that place does matter, even in an area that's as wealthy as this one. And so for the odds of food insecurity increased up to 5-fold, comparing the least healthy areas to the most healthy areas. So then there might be opportunities in there for intervening at a community level. Are people getting the right access to healthy foods in those areas? Do we need to provide more support in those areas? Do we need to add you know, other options for people to more food pantries or whatever it is, or other things that help alleviate the problem? And then the last study, being here on the US campus, on a college campus, we have to understand about what students are going through. And just to understand their attitudes and how they were feeling about returning to campus. So my colleague, Dr. Buckner, and I worked on a campus repopulation study to understand what students were dealing with and what their concerns were. So these were students in any institute of higher education intending to enroll in fall 2021. And we had over 4,000 provide complete information on vaccination and intent to return to campus. And so we found that about 18% of the students at the time hadn't been vaccinated. And their primary concerns mostly were side effects. They were worried about side effects. They were also worried about the vaccines that they were developed too quickly. And then we also found, we looked at what factors influence vaccination status, okay? So social factors and demographic factors. So by far, the strongest that we found was whether or not a household member had been unvaccinated. So if your household member was not vaccinated, you were 900% or 9 times more likely to be unvaccinated. Also political affiliation. So compared to those with no political affiliations, progressives were more likely to be vaccinated, 90%. Democrats were about 60% more likely to be vaccinated, and Republicans were 60% more likely to be unvaccinated, okay? Gender, males were 30% more likely to be unvaccinated than females. We didn't find any difference for for gender minorities. That was about the same as females in terms of the risk. And then source of information was also a pretty interesting one. So compared to those who had multiple sources of information, those who relied on friends and family were 50% more likely to be vaccinated, or those who relied on a health authority were 30% more likely to be vaccinated. However, those who said their source was other, like they said, oh, I do my own research, or I Google, they were 90% more likely to be unvaccinated if they had one single source. Okay, so this study actually points to the importance of social networks in terms not only for vaccinations, but of all health-related issues, and how that is important in how people connect with each other and make decisions about their health. So, you know, in this endless loop of the coronavirus, what's next? Many, many open questions remain. First, we need to understand the effects of COVID-19 of the disease on future health outcomes. There was a study that was published in Nature that showed a small but increased risk of cardiovascular outcomes among people who have previously been infected with, who have previously contracted COVID. There's some anecdotal data from Germany, not anecdotal, some data from Germany that talked about some increases in the risk of vertigo after receiving the vaccine. So is there something there as more study? So that's an open question for more studies to examine that. What is the impact on mental health? We have seen that mental health increased during the pandemic. Is it going to go back down, or are there latent effects? Determinants of long COVID. And so what's happening there? We know some people who are taking a long time to recover from the disease. So what's happening? We need to understand that more. I am most interested in looking at the long-term effects of the vaccine. I know Dr. Buckner and I have sort of started scratching the surface of that. And then another collaborator of mine in Germany and I will be looking at long COVID later. So lots of work for my sabbatical. And then lastly, also, what are the consequences of ending government protections? We had, because we were dealing with a public health emergency, there were various protections that are now ending or have ended. For instance, in California, landlords were not allowed to evict people. People had supplemental Medicare coverage, vaccines, testing from COVID-19. Tests were covered by insurance companies. We could, all use our insurance cards to buy tests. No, insurance companies are no longer required to do that. So all these structural factors that we have seen that have improved outcomes of people are all going away. And, as a public health professionals, we know that structural factors are important. And so I would hope that not all of these go away. Okay, so I just wanted to acknowledge the SJSU Central Risk of Funding for getting me started on this journey. The study participants of the Compass 1 and 2, the National and Bay Area Food Insecurity Studies, and the Campus Repopulation Studies. My collaborators, Dr. Angie Buckner, Dr. Vanta Park, and the Compass research team, and Dr. Gisele Pignotti. Research assistants, I have a bunch who are still talking to me despite all the groundwork that they did, and sometimes iterative, sometimes we didn't know where we were going. Kushbu, Asija, Arden Castle, Julian, Cherez, Kim Dang, Ashni Gundan, Osaji Oaya, Vasundra Metra, and Hanit Kaur Renata. And then also some graduate students in nutrition that Dr. Pignotti was mentoring, that I was helping out with, Dr. Adriana Tilias, Iris Tablas Mejia, Andresa Silvera, and Natalie Coatani. And then I have here some peer-reviewed publications from the studies that I had discussed, and then some research briefs as well that we developed, and then some additional data to support these. And that's it. I know I had to rush in the end, but thank you. All right, questions, comments, concerns? Yes, go back.
Hi, Dr. Dougan, Jarrell here. One question I want to ask you. So just recently, the public health emergency expired for the federal government. Basically that emergency basically kept insurance intact for those people who lost medical insurance or who had medical insurance because of that emergency order. How will this impact those insured with the emergency order that expired? And then my second question is, recently they've removed the booster vaccinations, like the requirement for booster vaccinations to be required for healthcare workers. Would that be the best step in going, or do you think that they should continue requiring boosters in healthcare facilities? Because as a healthcare worker, we were more prone to getting infections and that sort of thing. So what is your opinion on that as well?
So the first one, well, we know that having health insurance means better access to care, not just for coronavirus, but for long-term health. So it's, I'm hoping one day that we'll have universal healthcare in the US. And so it just makes me nervous that we have lost that. And, in terms of the requiring, again, that unfortunately, it's been made into a personal choice. I mean, for me, I would just get everything that's out there, at least based on the information I know now. But people, I would, that's a personal choice. I would say I think it should be required, but I'm not the one making the decision. But I wouldn't rush to just abandon vaccination altogether. Yeah, I know it's not the best answer, but yeah. I saw another hand. Did I?
Yes, I'm online.
Oh, okay. Let's see. So Carly Lowe is asking, the graphics comparing COVID to other pandemics made me wonder how it compares on duration thus far and the rate of infection in proportion to duration. Do you know if there's any information out there about that? I would say yes. I have not spent too much time on that literature, and I could look that up for you, but I can't tell you off the top of my head. But I'm guessing that there is something. There is definitely some information. Like I know our biologists probably know a little bit more about that, or virologists. But I have not spent too much time with that literature, but I'm pretty sure that there will be. Michael Elliott, any lessons learned on how to improve vaccination rates amongst college students? So in terms of that, I think it's the power of social networks is definitely important. I think, you know, legitimately people were concerned about the rate and the speed at which the vaccines were developed. As public health professionals, we have to go with the information that we have, especially, and look at the risks, right? At the time, especially when the virus was new, people were dying from it, as opposed to a vaccine that was safer and more effective. Effectiveness has waned over time as new variants have come out. So this is a tough one that we're in, because there's so much that's changing throughout. But in terms of, you know, just improving vaccination rates, I would say public health messaging, and also using the power of their networks, their social and their societal networks. Laurie Drabble, tell us where you're taking your research next. So first thing I'm going to do, as I mentioned, is look at what the literature is out there on with Dr. Buckner on the long-term effects on the vaccine, if any. On the COMPASS study, we have continued to recruit participants, and so we're looking now across time, what have their experiences been? So we just started looking at that qualitative data analysis. That's Dr. Buckner's wheelhouse. So I'll be learning a lot from her in there as well. So Leanne, hopefully I answered your question about what I would like to research earlier. Do you have an opinion on how the CSU's decision to lift all vaccination? No, I don't have an opinion. I do, but I don't. I'll wait till June, whatever. When I find out whether I get tenure or not, then I'll tell you. Okay. How your research has reached those who deny. Yeah, that's a good question, Adina, in terms of those who deny the pandemic is real. That's a tough one. It's hard because yeah, there's a lot of information out there denying the pandemic is real. We have not really come across a lot of that, because maybe it's just a selective group that are responding to the surveys and those who actually believe. But that's a very interesting question to try to understand. Sylvia, would you recommend supporting ongoing periodic vax clinics on campus and awareness to keep informing our community for health awareness, outreach, and convenience? Yes, definitely. As we have seen, the disease is not going away. Hopefully, we can get ahead of the variants in terms of having the right vaccines, but currently we're lagging behind that. So we want to make sure that we can get ahead of that. And if we have the right vaccines, yes, I would recommend to continue doing that, and just not to forget the importance of this. Yes, Miranda.
That's okay. Just want to make sure people online.
Yeah. So your research looking at discrimination against Asian Americans and food insecurity and the systemic racism that was manifest really vividly through the pandemic. Those are kind of circumstances that are part of American culture or American systems without a pandemic, that the pandemic kind of exposed, maybe exacerbated. And I'm wondering, as you kind of are keep continuing your research, how you think things will go, like where you think people's awareness or passion to try to solve some of these problems, if the kind of lens of the pandemic is waning as an effective tool to shed light. Like, what are some ways to still talk, like Jarell was talking about the end of the insurance, like also the end of supplemental nutrition, you know, that bonus to help people get more money when they are food insecure. Like what can we do, or what is your research going to do to try to keep this light on these bigger systemic problems that the pandemic only illuminated and exacerbated, but didn't cause?
Yeah, so that's a very good question and an important one. It's hard, I will say, because the more I think we're sort of forcing ourselves to go back to normal, where normal wasn't really working for most people, I will say, or for many people. And so we can continue to do the research, continue to engage in the public discourse as much as we can to keep these issues forefront in people's minds. But that is my fear as well. And I do feel like some of all the lessons, it seems like we haven't embodied a lot of the lessons the pandemic has taught us as a society. And, you know, for instance, rushing back to the workplace, well, there was a study that showed that Black people were really reluctant to go back because of all these microaggressions that they face in the workplace. But yet they're using that as a tool now, as a stick. Go back to the office or you lose your job. So we have not really taken a lot of those lessons, unfortunately. Yeah, but we'll keep, you know, communicating and engaging in the public discourse as much as we can.
Do you want to pick one more question and then we probably need to wrap up? I like the surprised one. What surprised you the
what
most?
surprised you the most in the research you have completed thus far? I would say with a campus repopulation study, just the power of networks in informing people's choices and actions about their health. That was the most surprising.
Awesome. Let's thank Dr. Dougan for amazing talk. And thank you all for being here. And thanks again to the team in the library that helps put this together and being so nimble in making sure this is built. But there's a lot more to come. Excited for you to get back from your sabbatical and tell you all about what you've been doing on that trip. So thank you, everybody, and enjoy the rest of your day. Cheers.